Hello.
Hello, we'll be starting the meeting now. I'll start by a quick introduction before our speakers talk. So welcome everyone. Thank you so much for joining. This is our second webinar on our series on the occasion of opening our fully fledged New Cairo branch. It of course includes state-of-the-art equipment with fully fledged services, including all MRI, CT, PET-CT, and PET-MRI, and other radiological services. This is a series of webinars with a special highlight on the PET-MRI applications. I'm proud and honored to present to you our distinguished speakers, Professor Dr. Yasser Abdelazim, Assistant Professor Wafa Rafat, Associate Professor Rasha Salah, and Dr. Yahya Omar Hussein. They're all Ain Shams University distinguished professors, and of course highly experienced, and they've done a lot of very advanced applications in their during their time at MRC and in other places. Our leader for today is Professor Dr. Yasser Abdelazim. He's the head of our MRI unit. And of course, our PET MRI new unit in New Cairo. Last week, we've discussed applications, the PET MRI applications on neurology, with a special highlight on brain tumors, epilepsy, and dementia by Dr. Yasser Abdelazim. This week, we'll be presenting oncological applications with Dr. Yasser starting with liver and pancreas applications, followed by Dr. Wafa discussing breast and female pelvis, then Dr. Rasha discussing prostate and rectal applications, then finally Dr. Yahya with the PET MRI using DOTA-TATE, PET MRI applications using DOTA-TATE. And of course, we welcome any questions. So if you have any questions, please feel free to write it down in our chat during the time, or of course, we'll be opening the discussion later on for questions. So you can either write your questions right now so that you don't forget it, or you can just unmute yourself after the time is done, and then you can ask the question. We'll be asking the questions in a sequential order upon receiving them. Thank you so much for joining, and Professor Yasser, please start right now.
Bismillahirrahmanirrahim. Thank you, Doha, so much for the nice introduction. And as Doha mentioned, last week we started our first webinar by talking about neuro applications, and I talked about brain tumors, epilepsy, and dementia. And for any of you who didn't hear it and he wants a copy of the presentation, I am willing to send it to him. Just contact us today. Now, for the purpose of this webinar, we will be discussing on PET-MR oncological applications all over the body. I am going to start with the liver. And first, PET-MRI, what it is. Well, all of you know, or most of you know, about PET-CT. PET-MRI is a similar hybrid imaging technique where you get metabolic, functional, and anatomic imaging or images together in one-stop shop exam. The advantages of MR is that besides the anatomic issues, we also can get functional stuff from the various MR techniques. This is added to the metabolic information by the PET. This is the machine. It is like any other MR machine, but the PET ingredients are within the gantry over here, so that the patient is simultaneously imaged by MRI and PET at the same time. So they are one and the same exam, both of them done together, so you get the benefit of both worlds. Why PET-MRI in cancer patients? This is because we are combining the superb soft tissue contrast of MRI using T1, T2, fat suppression, pre and post contrast techniques, which is giving us the anatomy and the structure. Then we can combine this with the vast capacity of MR techniques on functional and metabolic level, like assessing cellularity of the tumor by diffusion weighted, vascularity or microvascularity in better terms of the tumor by perfusion, whether it's permeability perfusion or fractional perfusion, as well as MR spectroscopy. So we get also functional data. Last but not least, the PET component comes in, giving us the molecular metabolic data. So we are having anatomy, function, metabolism, all in one stop-shop exam, which is very beneficial for initial diagnosis, initial staging, and subsequent follow-up and restaging of various cancers and follow-up after treatment to monitor response to treatment and so forth. What are the benefits of doing PET MRI? Four main things. You have a better TNM staging because you are, and let me here say, unlike PET CT, if I may, you are doing the tumor itself, being it breast cancer, rectal cancer, prostate cancer, liver cancer, whatever. So you are doing it in the most efficient way by MR technique on 3 Tesla MR unit to get the T staging. Not only this, but also for the N and M, you are getting a whole body MRI, which is the PET component, but PET component combined also with the high resolution and higher information on metabolic, on structure and metabolic level of MRI. So even the nodes and metastases, we evaluate them better in this regard. So we are combining T, N, and M in one-stop shop exam. You don't need to do MRI high-end separately and then go for a PET study separately. As such, we have shorter study time overall because you don't have to do 2 appointments and 2 studies and 2 different preparations and 2 different contrast agents, etc. It's the same cost or even less because when you combine the price of a high quality MRI and PET CT, you will get nearly the same price by doing PET MRI and with the higher beneficial capabilities I just mentioned. Also, last but not least, there is no radiation exposure. And this is very, very, very important, especially in children and people with long-term follow-up who are going to get frequent studies. We don't want to expose them to radiation. And as I said last week, actually nearly all pediatric hospitals abroad, especially in the USA, where I visit them, they were the first to incorporate and integrate a PET MR scanner for their sick children in order to follow them up serially without radiation exposure. Now, as for the liver, in particular, I'm starting with the most common liver tumors. What are the most common liver tumors? Metastasis, of course, as we all know, and which is the most pertinent for the oncology world. So we get PET MR data and for the liver and also for various parts in the body. So not only the liver, for any other part, we see the metastasis, and particularly in this exam, we also see brain metastasis, which is rather a somewhat dismerit or disadvantage for PET CT because of the high avidity of the brain to glucose. Here we use both the PET data, but also our MR data before and after contrast to detect brain metastasis. So we are doing a full, high quality metastatic workup. Let's start by this case, breast cancer, liver metastasis, seen on T1 weighted, on the CT. Not all of them are seen at all, maybe this large one only, the others are vague. Then the PET MRI depicts these lesions by their high uptake, which is, to my eyes, somewhat better than the PET CT data. And surprisingly, in this case, diffusion of MRI and ADC even detected more metastasis than the T1 and the PET. This is not always the case, but this shows you the power of MRI with its initial sequences, including diffusion. However, this is not the case all the time. Sometimes PET does the job. This is a PET MR in another case of breast cancer. And here we can see that actually the PET is the one that made us confident that there is actually a metastatic deposit, while in the post-contrast T1, it was barely vaguely seen, and on T2 and other sequences that was maybe can be considered as a vessel, but the PET MR was the one that gave the job, or the PET in particular. So this shows you that this combination is very beneficial because in every case, one of them is the stronger and benefits us. Another case of liver metastasis with PET MRI, and here we see on the T2 and on the ADC of diffusion, and then the PET MR to my eyes also better depicts it than the PET CT, where it is actually not that quite seen. So these small peripheral lesions, MRI with all its capabilities and adding PET to it gives us the edge. Colon cancer, very common. Again, we can see the beautiful demonstration of the high uptake and the by the FDG PET tracer, and in a case of colonic cancer, and confirming what we are seeing are actually metastatic deposits. Another case of colon cancer now for these small peripheral lesions that are not easily detected on PET-CT or questionable, like in the upper row, but on MRI by T2, and then by the PET, the initial PET data and the hybrid PET MR data, we are sure that we have a metastatic deposit. Moving on to hepatocellular cancer and cholangiocarcinomas, here I want to show actual cases which we did at our center. So we had a 77-year-old male with liver cirrhosis, developed HCC on top, had radiofrequency ablation. We see all these cases all the time. Now coming with recent abnormal elevation of alpha-fetoprotein, suspecting recurrence. So we did our PET MR study. For time's sake, I don't want to go to all the sequences, but suffice us to say that we well detected de novo lesions in this liver, which were so difficult to see by other modalities. And they are having the early arterial uptake and then wash out, and they have the high uptake on PET. And even the one that was ablated also showed somewhat higher uptake than the background liver. This for us was quite interesting because we can also say that this one has some sort of activity. So why they are not that much vivid on the PET? Our interpretation was that because these are well-differentiated HCC. So for well-differentiated HCC, you don't see remarkable high uptake and high SUV values like in poorly differentiated HCC. So the SUV values, as you can see from the table we performed here, were in the range of 2.4, 2.5, which is mildly higher than the hepatic parenchyma because they are well-differentiated HCC. And what happened with this patient was actually that these lesions, as we are concluding, seemingly progressed over time along the pathogenesis track of HCC. Ayo? These progressed along the track of HCC from being regenerative nodules to dysplastic nodules to early well-differentiated HCC. So now we are picking them up at the early well-differentiated HCC, explaining the elevated alpha-fetoprotein and giving him a chance for better treatment than if he would progress to the poorly differentiated HCC. Another case where 81 years old, had right-sided abdominal pain. This was an interesting patient because he had elevation of carcinoembryonic antigen, but no elevation of alpha-fetoproteins. He has a big, ugly hepatic focal lesion occupying most of the left lobe. And then there is a PET uptake at the periphery, the very much vivid and very much noted at the periphery of the lesion. The center is necrotic. There is low ADC at this part due to high cell packing. The triphasic pattern was, to us, was between calling it cholangiocarcinoma because of the more delayed uptake, or fibrolamellar HCC because of the size and the other criteria. Not only this, we detected several metastatic deposits with mostly osseous, and especially the small retroperitoneal deposits and the nodal deposits within his body. This is the original PET. This is the hybrid or fused PET data. And we gave all this quantitative data, not only using SUV max, but combining it with ADC values from our MRI. So we have two quantitative parameters with us to be used for further future and follow-up. And this is done for the hepatic focal lesion and for all the deposits. And then in our conclusion, we said that we are more inclined to calling it fibrolamellar HCC. Now, some of you would argue that fibrolamellar HCC is in young patients. Yes, this is the usual age, but in the literature, there have been cases reported in older age group. And then we could not also exclude cholangiocarcinoma. Cholangiocarcinoma, the issue about it was that we had muscular deposits, which is not common with cholangio. So we were between these two diagnoses, but we did our job. We did the staging, T4, N2, M1, local or distant. We said that this is not our typical HCC. The liver was not cirrhotic, so it's between these two entities, and we are waiting for the histopathology. Now, why do we do quantitative assessment for liver tumors? And we use SUV, like in this table over here, but this is because it helps us predicting operability, aggressiveness, response to therapy, long-term survival. You want me to stop? And long-term survival, and not only we get SUV data, but also ADC, K-trans, perfusion fracture, choline to creatine from MRI. I'm just going to finish by these two slides, one for an initial pancreatic cancer, initial staging of pancreatic adenocarcinoma, and we can see the vivid uptake of the pancreatic cancer in the body of the pancreas over here in the PET studies, and confirming the MR and ruling out that it could be inflammation or anything else. And having very high SUV of 8.7 going with malignancy. The other case is for the follow-up by MRI, very nicely here, pancreatic head cancer with a very high SUV of 22, then dropped to 3.8 after 6 cycles of therapy. I think I have to stop now. I have some slides about MSK, if tumors, if time permits, after all the speakers are finished, then I can show them to you. So thank you for now, and the floor. I think we decided that all questions will be at the end after the 4 speakers. So Doha can go ahead and introduce the next speaker.
So our next speaker will be Associate Professor Dr. Wafa, talking about breast and female pelvis applications of PET MRI. Please go ahead. Dr. Wafa?
Yes, I'm with you.
Thank you.
Just one moment.
For everyone else, please make sure you're on mute all the time, please.
Wafa, would you like us to go to Russia and then you can talk after her?
No, actually, I'm trying to share my screen, but I have a message that I cannot start screen sharing while other participant is sharing.
Dr. Yasser, please stop sharing first. Yes, exactly.
Yeah.
Can you all see my screen now?
Yes, Dr.
Yes, Dr. Wafa, please proceed.
Okay. First of all, hello everyone. Happy Ramadan. Thank you, Doha, for the introduction. Thanks, Dr. Yasser, for the valuable knowledge you gave us earlier. Now, I'm going to talk about the PET MRI applications in female oncological imaging. Now, this slide is a repetition of what Dr. Yasser just mentioned. I just want to say that we all know that MRI is the modality of choice in the local staging of breast malignancy and the assessment of female pelvis. So let's start. Now, the idea of applications of PET in breast tumors is that the intensity of FDG uptake is related to the biological and histological characteristics of breast tumors. Now, this is what makes it uniquely avid to invasive ductal carcinoma, while poor uptake is appreciated in case of invasive lobular carcinoma. So the selection of patients, whether they are according to the different subtypes of breast malignancy, is of utmost importance. And this is when we are talking about PET-CT. Now, MRI overcomes this because we can detect the primary tumor, whatever its subtype is, whether we are talking about invasive ductal carcinoma or invasive lobular or even ductal carcinoma in situ. There is a positive correlation between FDG uptake and the tumor grade, together with the tumor proliferation index, and also issues related to the receptors. This is an example showing us different cases here between the STAIR MRI and the PET. We can see that there are lesions, malignant. They are histopathologically proven malignant lesions in all the breasts. An ugly, sizable lesion, two smaller lesions, another lesion. Now, the idea of this is to show us the uptake of these different lesions. Now we can see here that this is a lobular carcinoma and it shows no uptake on the PET. And then we can see that there are two lesions here. One of them shows uptake, and then this is of less avidity. This was a DCIS compared to an invasive ductal carcinoma, and another case of invasive ductal carcinoma. So we can see, according to these cases, that there are different forms and different patterns of uptake. Of course, we know that the newly introduced PET study, the PEM, the positron emission mammography, but the idea of this is which shows a higher sensitivity, yet there is no coverage of the whole body. And so this is what makes PET MRI of edge, because we are performing a multi-parametric MR study of the breast, including the all pre-contrast sequences, dynamic contrast study, and the diffusion weighted images that give us data about the cellularity of lesions, as we can see here. This is a malignant neoplastic lesion, a case of lobular cancer with the accentuated contrast enhancement, the type 2B time intensity curve with the initial rapid upslope of contrast, and then we see the downslope, the slower downslope of washout. We can see the ADC map showing us the significant cellular packing. And then we have the application not only as performing this superb locoregional staging, but we also have the distant metastatic staging. Now, as I just mentioned, the role of PET MRI is for the locoregional staging with high sensitivity and specificity of the MRI, the nodal metastasis, and adding the PET has given us the edge of being more confident in calling metastatic, differentiating between metastatic and non-metastatic lymph nodes, together with its role in the assessment of distant metastasis. Of course, PET improved the detectability of metastatic pulmonary nodules. There is also the importance of adding MRI due to the problem I mentioned earlier in the detectability of metastatic lesions in a setting of low FDG affinity tumors, especially when we are talking about lobular carcinoma. And then we also have the role of MRI in the detection and characterization of hepatic focal lesions. Namely, we are talking about metastatic lesions, as Dr. Yasser earlier showed us a case with much heavier hepatic metastatic load on the MRI compared to the PET-CT. Now, these are examples of cases. First of all, we got the invasive ductal carcinoma. We have its pattern of enhancement with the skin infiltration on MRI. We have its diffusion weighted image and the corresponding ADC map showing the cellular packing. And we have the corresponding PET study and the fused PET MRI images. Okay, this is a straightforward case showing us the cross correlation between the PET and the MRI. And then we have another example here of invasive lobular carcinoma. We have an infiltrative lesion here on MRI, and there's another lesion in the contralateral breast in comparison to the PET-CT study that showed us we couldn't delineate the lesion based on CT density, first of all. And then again, there is the low avidity to FDG. So accordingly, MRI would be much more sensitive in this setting. This is another example of a DCIS, ductal carcinoma in situ. Again, we are talking about a very small lesion on MRI, and this is the time intensity curve, again, a type 2B. And then we have its PET, on the PET study, we can see that there is faint FDG uptake, which was obscured by the background of normal parenchymal, breast parenchymal uptake. Then we have, so accordingly, I just showed you these cases because when we are selecting the patients, it is of utmost importance to select them based upon the avidity and affinity of these lesions to FDG, because it will not only affect the decision-making for locoregional staging, but also for the metastasis. Because again, if the lesion from the start is not of a low avidity to FDG, then again, the metastatic load will be underestimated if the proper study is not performed. Examples of the nodal disease, as I said, it is much better, we call out malignant metastatic lymph nodes much better and with much better confidence based on the fusion and the FDG uptake of these lymph nodes, because originally on MRI, normal lymph nodes or reactionary lymph nodes could show diffusion restriction. So accordingly, we are relying on their alteration in appearance, being globular, rounded, loss of sinus fat, or eccentricity of the sinus fat. So again, PET is in this setting of utmost importance. This is another example showing us the same raising the confidence of calling out it metastatic rather than a reactionary lymph node. And then we got the distant metastasis. It is being a this case, Dr. Yasser showed us earlier, again, the edge of MRI showing the metastatic load, especially when talking about the liver. And of course, when talking about osseous deposits, when the initial breast tumor is of low affinity to FDG. So the detectability of the lesions is much higher when adding the MRI in certain settings. Okay, this is a representative case which we performed lately, about a couple of days ago. It shows us it's about a 56-year-old female patient who gives a history of left breast malignancy 5 years ago. She was subjected to surgical intervention and she received chemo, radio, and hormonal therapy. Her PET-CT 2 years ago was completely free. This operative bed, together with the whole body, it was free of metastatic involvement. Recently, her lab profile revealed elevated tumor markers, and accordingly, a PET MRI was done. As you can see here, this is the fused PET MRI showing us a high avidity or a hypermetabolic lesion at the lateral posterior aspect of the left breast. This is the post-contrast study showing us an ugly looking irregularly outlined lesion with speculated margins. And this is the type 3 time intensity curve of the lesion consistent with recurrence, tumoral recurrence. Furthermore, we found out that there was contralateral metastasis to the right axillary lymph node. As seen, it is of low signal on T2 weighted images with the diffusion restriction, and here on the ADC map, and it appears as a focal area of FDG uptake on the PET study. Again, in the same patient, she showed soft tissue metastasis. There was a soft tissue metastatic deposit closely related to the celiac trunk and infiltrating the left cross of the diaphragm and extending to the left suprarenal gland, showing a hypermetabolic status with an SUV of 5.6. Another soft tissue metastatic lesion was seen at the left aspect of the rectovaginal pouch, giving an SUV of 6.8. The same patient, she showed a rather heavy osseous metastatic load implicating the vertebrae at different levels, together with the left iliac bone, left pubic bone, the inferior pubic ramus, together with the right femoral neck. There was also sizable hilar and mediastinal lymph nodes showing increased uptake of FDG. And so as we can see, this is the 3D PET image showing us the the recurrent left breast lesion, the lymph nodes seen on the right contralateral side, a scapular lesion, the lymph nodes, the soft tissue affection or the soft tissue metastatic lesion seen within the abdomen. This was also very helpful because on her MRI study, there was the apparent thickening of the endometrial lining, which was inhomogeneous. And in a setting of breast cancer and on hormonal therapy, suspicion was raised of the probability of endometrial cancer, but then the diffusion weighted image and the PET were helpful in ruling this out. This is endometrial hyperplasia based on the diffusion facilitation with no areas of frank diffusion restriction. This is the ADC map, and we can see we can see that there is no significant FDG uptake related to the endometrial lining. As for pelvic malignancies, again, here we are talking about the locoregional staging, the nodal metastasis, and the distant metastasis, similar to what I mentioned as regards the breast. Examples of this, we are talking about the uterine cervical cancer. when we are assessing the local disease, it is of utmost importance, of course, you all know, to mention or to be able to characterize the, to accurately characterize the stage of the tumor according to the FIGO classification. And of course, MRI has an edge and is of high sensitivity and specificity compared to CT. PET-CT shows a low accuracy reaching 63.3% compared to the MRI, which reaches 93.3%. Furthermore, of course, when we add the high soft tissue contrast of MRI to the functional data of both MRI and FDG, we reach a better diagnostic performance. As we can see, this is just an example of an early stage 1B1 cervical cancer involving the posterior lip, show of a low signal on the post-contrast, delayed post-contrast image. And this is the fused PET MRI showing the high avidity of the lesion. So it is helpful in the staging and in adequately calling out the stage of the lesion and extent of involvement of the surrounding structures. This is another example of a uterine endometrial cancer. Now, MRI offers a much better diagnostic performance than transvaginal ultrasound and represents the reference standard for staging of endometrial cancer, because contrast-enhanced MRI and diffusion-weighted images provide indispensable diagnostic data concerning the myometrial invasion, because the less than 50 or more than 50% invasion has its influence on recurrence and its influence on the liability of nodal and distant metastases. FDG PET is relatively lagging in comparison to PET MRI in predicting myometrial invasion and detecting early parametrial involvement, and in more precisely verifying the peritoneal metastatic load. This is an example of a case of endometrial cancer, showing us the tumoral bulk filling in showing us the tumoral bulk with the focal areas of infiltration of the myometrium. Again, this is the high avidity of the lesion seated within the endometrial cavity, and showing us also the extensions into the myometrium, the uterine myometrium, and the invasion of the, and delineated within showing us the invasion of the cervical stroma. There is also its role in the ovarian cancer. Based on studies, the PET MRI has been reported to have higher sensitivity, reaching 94%, and specificity reaching 100% in the characterization of ovarian tumors, compared to MRI on its own and FDG PET-CT. This is an example of a multiloculated mucinous adenocarcinoma of the right ovary, showing the mural nodule with the high avidity. And then we also can see on the whole body the mesenteric involvement of the mesenteric deposit, furtherly upstaging this cancerous case. To sum up the benefits of simultaneous imaging, and of course I'm talking about its role in female oncological imaging and in general in different oncological settings, is that it is a one-stop shop examination. It combines the benefit of the superb soft tissue contrast of MRI, adding or combining the functional MR data, including the diffusion, perfusion, and spectroscopy, together with the functional metabolic data of FDG PET. And what is of utmost importance, and that I would like to highlight, is that we tailor the study according to each and every patient. So you can find that in different patients, the study will cover the whole body, but the selection of the local coverage will vary according to the setting of each patient. So the patient benefits the utmost from the PET MRI study. Thank you very much.
Thank you so much, Dr. Wafa. Our next speaker is Dr. Rasha Salah with an overview about the prostate and rectal applications. Please go ahead, Dr. Rasha, if you're ready.
Hello, everybody. Welcome to this webinar. It's my pleasure to be here with you today. We are going to highlight the role of PET MRI in oncology. We are going to focus just on two we are going to discuss today the prostate cancer evaluation and rectal cancer evaluation by PET MRI. I will skip this introduction because it was very nicely introduced by the Professor Dr. Yasser and the dear colleague Dr. Wafa. Starting with the prostate cancer. The current initial staging for prostate cancer include multiparametric MRI as recommended by multiple guidelines. And if the patient is classified as unfavorable, intermediate to high risk patient, then further assessment by CT abdomen and pelvis for nodal evaluation, and also for bone scan to evaluate osseous lesions. And if there is an equivocal lesion on the bone scan, then PSMA PET studies could be asked. The value of PET MRI in initial staging, not for the evaluation of the prostate cancer, but it is manifested to be more effective in nodal staging, and this meta-analysis evaluate the value of PSMA PET-CT in nodal staging regarding and comparing the conventional tools for staging of the lymph nodes. And it reveals that there is a significant increase in the sensitivity, the specificity, and the positive predictive value for the nodal staging. And the current studies were discussing the value of PSMA PET MRI compared to PSMA PET-CT as regards nodal staging. And some initial results reveal that the PET MRI is more sensitive in detecting nodal staging due to the longer acquisition time, which allow detection of more avid lymph nodes during this long acquisition. This is an example of a patient that was recently pathologically proven to have grade group 4 prostate cancer with high PSA level. This is the state-of-the-art MRI showing diffuse infiltrative mass lesion implicating the peripheral zone, mainly on the right side with extracapsular extension. And this was confirmed on the diffusion weighted image with the diffuse infiltration of the peripheral zone, and associated another nodule at the central gland is also noted. And this was very concordant on the PET MRI with significant increased uptake. As regards the nodal staging for this patient, we can see that there are ugly looking right-sided pelvic lymph nodes, and they were proved to be positive metastatic nodes on the fused PET MRI. But also we can notice here that there is unusual presentation with the perirectal enlarged and the suspicious looking MRI that was confirmed by the fused PET MRI to be a metastatic lymph node, and this was very important if surgery is a plan for this patient. And another lymph node was depicted on the left hypogastric lymph node, and it is small on the conventional images, but the avid uptake on the PSMA PET study confirms its metastatic nature, and so this could be change the patient staging and the surgical plan for the patient. No other osseous or distant metastasis could be detected. PET MRI is very helpful in characterization of small lymph nodes, which are difficult to be characterized in the conventional image. Here we can see small right pelvic lymph node, and this is the left supraclav lymph node. They are non-specific on this conventional image to call them metastatic lymph nodes. But when performing the PSMA PET MRI, they were proved to have avid uptake, and they were pathologically proven to be metastatic. And another example for the value of PET MRI is the concordant uptake between the PET MRI and the conventional MRI regarding the seminal vesicle infiltration. Also, the fused PET MRI shows more primary involvement of the prostate than the conventional MRI. But due to the conventional staging by this patient, bone scan was asked and it was negative for any distant metastasis. And initially, this patient was staged as non-metastatic patient. But this multi-parametric MRI with the fused PET MRI shows not only regional lymph nodes, but also non-regional lymph nodes, including thoracic and right supraclav lymph node, which completely changes the stage of the patient into a metastatic 1A disease. Another value of MRI is that detecting early metastasis in osseous lesions. Here we can see a subtle signal alteration at the right acetabulum that proved to be malignant with avid uptake on the PSMA PET MRI. Another lesion is seen here. It is very hard to detect on this MRI alone, but it was confirmed by the fused image to be a metastatic deposit. As regards biochemical recurrence, it's very important to perform a PSMA study to detect local recurrent disease and also establish the metastatic load of the patient, especially if the patient is oligometastatic with the curative intent is needed. This is an example with the previous radical prostatectomy showing pelvic fibrosis over here, but the dynamic contrast enhanced MRI showing hyper-enhancement at the left pelvic fibrosis, and this was concordant with the fused PET MRI study to be having avid uptake and proved to be metastatic deposit. There is a small non-specific lymph node noted here at the right, at the left aspect of the pelvis, and this was proved to be avid also on the fused PET MRI and pathologically proven to be malignant lymph node. As regards rectal cancer, the current staging include local staging and by a dedicated MRI protocol, and then the patient underwent metastatic workup, including CT, chest, abdomen, and pelvis, and sometimes whole body PET CT could be asked to assess the metabolic changes after the chemotherapy. The value of PET MRI in rectal cancer, it could be used in initial staging, not only for staging the local tumor affection, but also it is very valuable in nodal and distant metastasis. It is valuable in restaging after concurrent chemoradiotherapy and also assessment of recurrence. Let's start with the initial staging. The T2 and the fusion were concordant with the fused PET MRI study with significant avid ugly looking anterior rectal mass lesion. PET MRI is more valuable in nodal staging than evaluation of the rectal tumor itself because there is more depiction of more avid lymph nodes, especially in the non-regional lymph nodes as demonstrated by this study. And this is an example for an ugly looking mass noted at the right aspect of the rectum. And this was the ADC map showing high cellularity of this tumor, and this was concordant with the fused PET MRI study with significant avid uptake. Unfortunately, this is not only the case of the patient with advanced ugly-looking rectal mass with some regional lymph nodes, but unfortunately there were non-regional lymph nodes at the para-aortic group. They are small and non-specific on the non-conventional imaging, but here on the fused image, they were manifested as metastatic lymph nodes and completely changed the patient stage into metastatic disease. And this was also confirmed by another study evaluating the value of PET MRI in nodal staging, and they also demonstrated that the longer acquisition time in the PET MRI improved the detection rate of the FDG avid pelvic lymph nodes. And so it will end by upstaging the disease into a metastatic disease. This is an example with a small presacral non-specific lymph node. This is the acquisition at 3-minute acquisition PET CT. This is the PET image. The lymph node is completely negative. The uptake here is for this bowel. And then the PET MR shows increased uptake at this lymph node due to the longer acquisition at the PET MRI. And this is the fused image confirming that this non-specific presacral lymph node proved to be metastatic lymph node on histopathology. Another example is the non-expected lymph nodes. Here, by the conventional image, we can see non-specific right inguinal lymph node in this patient with rectal cancer. And by the conventional image, it is non-specific, not to be called as a metastatic lymph node. But when they performed the fused PET MRI, they show small focal uptake, and this was pathologically proved to be micrometastasis in this right inguinal lymph node, which completely changed the stage of the patient into a metastatic disease due to the non-regional lymph node affection. As regards distant metastasis, you will highlight only that the PET MRI is more additive than PET-CT, especially in liver evaluation for hepatic focal lesions, including T2 and diffusion, and this is more or less concordant with the PET MRI study. As regards the restaging, this is an example for a patient with the pre-treatment showing an FDG-avid rectal mass lesion. And after treatment, there is no FDG uptake and was classified as a complete radiological response based on this PET image. But the diffusion weighted image is still showing small areas of restricted diffusion. And as such, the MRI alone confirmed that the patient has partial response, not a complete response due to the residual viable tumor. But after surgery, it was histopathologically proven to be complete pathological response as the PET-CT, so it will be of value to perform PET-CT before and after concurrent chemo and radiotherapy. As regards the recurrence evaluation, it is a dilemma because there is usually fibrosis at the operative bed in the rectum. This patient who underwent the previous abdominoperineal resection and shows this ugly looking soft tissue structure in the pelvis with mixed signal intensities. Some areas of this lesion are hyper intense and others are low signal intensity. And on the fused PET MRI study, these are showing FDG avid uptake at the areas corresponding to the hyperintensity on the MRI, while the areas that shows low signal on the MRI are negative on the PET, and this was pathologically confirmed to be mixed fibrosis and areas of recurrence. So to sum up, PET MRI is concordant to MRI in local organ staging. PET MRI has an additive role in assessment of nodal affection, either regional or non-regional lymph nodes, as well as distant metastatic load. PSMA PET MRI is superior to PET-CT, especially in local recurrence for prostate cancer. MRI has potential role in evaluation of treatment response in rectal cancer, but it needs more investigation to highlight its role. PET MRI increases the confidence in discrimination between operative bed fibrosis from recurrence. Thank you.
Thank you so much, Dr. Rasha. Our next speaker is Dr. Yahya Omar, talking about our PET MRI applications using Dr.
Thank you, Doha. Do you see my screen now?
Yes. Please
I want
go.
to thank all the attendees for joining in. So I'll be giving this short talk on Galenotite PET MRI in neuroendocrine tumors. So we'll start by what is Galenotite tracer and why do we need it? Then move to the added value of Galenotite PET over routine FDG PET, and then move to our main topic of today, which is to highlight the added value of PET MRI. Let's start by what is Galenotite. It is a radioactive tracer that targets the somatostatin receptors that are overexpressed on neuroendocrine tumors. Why do we need this specific tracer? We need it because of two reasons. The first, it has very high sensitivity and specificity in neuroendocrine tumors, and that's why it is now recommended by the nuclear medicine, oncology, and endocrinology guidelines for imaging of well-differentiated neuroendocrine tumors. And the second point is that neuroendocrine tumors have low metabolism and low glucose uptake, so they do not show uptake on FDG PET. This is a very important point, and this is what we're going to see in the next cases. We had this patient presented with hepatic neuroendocrine metastasis, and he was referred to detect the primary site. They performed first an FDG PET-CT, and as you see here, we cannot see any hepatic active focal lesions, and also we did not detect the primary tumor. The patient did a dotatate PET-CT Now you can see a big difference between the two exams. We can see now the primary pancreatic neuroendocrine tumor as well as the multiple hepatic focal lesions that were not seen in the FDG PET. Moving to another case, the patient presented with newly diagnosed gastric carcinoid and referred for initial staging. Also, he performed FDG PET at first. We did not see the gastric carcinoid. And in the CT part, there was 2 small lymph nodes here and here, and they were not active. However, when the patient performed dotatate PET, again, big difference between the two exams. We can see the primary gastric carcinoid, and now the regional metastatic lymph nodes leading to upstaging the patient. Another final case for the same comparison, patient presenting with insulinoma symptoms. So we were searching for an insulinoma. Again, he performed an FDG PET. It was negative. And in the dotatate PET, clearly seen intense focal uptake in the pancreatic tail, clearly seen in the fused images, and not seen in the FDG PET. So to conclude this section, FDG PET is not recommended to image well-differentiated neuroendocrine tumors. And that's why we have this tracer. And that's why it is recommended by the guidelines to image well-differentiated neuroendocrine tumors. Now let's move to our main part of today, which is the added value of PET MRI. We had this patient, actually this patient did at our facility 2 weeks ago. He presented with gastric and duodenal neuroendocrine tumors, and he was referred for initial staging. So we found the gastric and as well as the duodenal nets and multiple metastatic lymph nodes. And we found this borderline lesion in the tail of the pancreas. Very low activity here with no correlation in the CT part. So after finishing the PET CT, we were not sure if this is a true lesion or not. So we transferred the patient after finishing the PET CT to the PET MRI machine. Now we can see the difference. Now we can see there is actually a pancreatic tail lesion and it's active in the fused images. So now we are confident and we are sure that this is a pancreatic tail neuroendocrine tumor. The first added value I want to highlight here is the ability of PET MRI to detect small pancreatic nets that are harder to be seen in the CT, especially if the activity is borderline like this case. So now moving to another case showing the same added value. This patient presented with hypoglycemia and hyperinsulinemia. So again, we are searching for insulinoma. The dotatate PET showed intense uptake here. However, in the CT part, there was no correlation. However, in the MRI, we can clearly see an arterially enhancing very small lesion in the uncinate process concordant with the PET findings. And this is why having data from the PET and data from the MRI, when they are both pointing to the same diagnosis, this is, raises our diagnostic accuracy a lot. Now moving to another application, as of course all previous speakers mentioned, the better ability to detect hepatic focal lesions. This patient had liver metastasis from pancreatic net. We can see active focal lesions here and here with faint arterial enhancement in CT. However, when the patient performed an MRI, we can see well delineation of all the lesions. And this lesion now, which was borderline here with faint enhancement here, is now clearly seen in the MRI and in the fused image. So this is the second application in dotatate PET MRI, is the ability to detect or delineate the liver metastasis very good, especially when they are small. And especially neuroendocrine tumors, the first site of organ metastasis is the liver. So the ability to assess the liver accurately in a neuroendocrine patient is crucial. And that's why I think this added value in the liver in PET MRI is very important for neuroendocrine patients. Another case showing the same added value. The patient had a primary pancreatic net. He had a regional lymph node and a borderline lesion in the liver. However, in the MRI, in the diffusion restriction, we can clearly see it highlighting the same added value of better assessment of hepatic mets in PET MRI. Now let's shift to a totally different application. This patient presented with headaches, hypertension, and elevated metanephrine levels. and all previous exams were negative. I performed first a dotatate CT. Now you can see this intense focal uptake in the right side of the neck. However, in the CT part, there was no definite correlation in the CT. So we were not sure, that's what they mentioned in this paper. They were not sure about the entity of this lesion. So they performed an MRI. Now we can see 5 millimeter lesion in the carotid bifurcation. And this is the carotid bifurcation paraganglioma. And this is one of the indications I want to highlight because it's not well known to everyone about assessing paragangliomas using gallium dotatate, and especially using PET MRI, because it will be able to detect these very small lesions that are hardly detected here, especially if the patient moves his head a little bit during the exam. It will be very hard to correlate this lesion in the CT, in the correlated CT part. So moving to another application that is also not known to everyone, and I want to highlight it, the ability to detect this enhancing small meningeal lesion. This is a meningioma. Gallium dotatate is very sensitive to detect meningiomas, as they have the same type of receptor as neuroendocrine tumors, which is somatostatin receptor. And we can use this feature in complicated cases like this one. This patient had recurrent anaplastic meningioma, post-surgery and radiotherapy. And now we can see enhancing masses in the left nasal cavity, in the left maxillary sinus, as well as enhancement in the inferior frontal lobes. So the question now was, where is the true extension of recurrence, and is there any post-treatment changes or not? So they performed dotatate PET MRI. Now we can see clearly difference. Here is the recurrent mass, active lesions, and the enhancement here was inactive, and that was compatible with post-treatment change. And here I want to highlight a big difference in the mechanism of action between the dotatate and FDG. Dotatate is a receptor imaging, so it is not affected very much by infection or inflammation. That's why we do not show uptake in post-treatment changes, not like FDG. And that's why we are able to assess the surgery and radiation early. We do not have to wait 1 or 2 months until the inflammation subsides. So this is a very important added value because of the type of mechanism. If we have the tumor, then we have the receptor, then we have uptake. No tumor, no receptor, then no uptake. So now moving to our last case, also a meningioma patient, and that's why I wanted to highlight it very much. This is a melanoma patient presented with growing meningeal enhancing lesion. So the differential was, is that a meningioma or melanoma metastasis? So they performed a dotatate, and now we see intense uptake here. So now this is a meningioma and not a metastasis. And this application, especially in the PET MRI, would be very helpful in patients that have tumors that have common metastasis to the meninges, as breast cancer. This application will be very helpful in patients like these to be able to decide, is that a metastatic lesion or that is just a simple benign meningioma. So to summarize and conclude, gallium dotatate is used to detect well-differentiated neuroendocrine tumors that are missed in FDG PET. Gallium dotatate PET MRI can especially add value in detecting small pancreatic nets, detecting small hepatic metastasis that can be missed in PET CT, detecting head and neck paragangliomas, as well as detecting meningiomas and assessing their post-operative recurrence. Thank you very much.
Thank you so much, Dr. Yahya, and thank you all doctors for the brilliant presentations and for all your efforts in preparing this. For everyone, we apologize for taking more time than planned. To ensure all questions are heard, please mention your name or your question in the chat, and I'll make sure I call out your name. As you have questions from Professor Dr. Hassan Shaker, please unmute yourself and feel free to ask your question.
Hello, hello, good afternoon, everyone. Actually, this was a very nice webinar, and I enjoyed it very much, even in the parts that are not urology. So I'll focus my questions to Dr. Rasha Of course, Rasha, you know that we do targeted focal laser therapy for prostate cancer using MRI ultrasound fusion. And we have a protocol with you in the center in which we do a follow-up for these patients. Do you think that PET MRI will add value to the multiparametric MRI in following up these patients?
You are welcome, Dr. Hassan, for this attendance. Actually, PET MRI for focal assessment of prostate was concordant to the multiparametric MRI. It is more beneficial for distant nodal and distant metastasis. So as regards the cases with the focal laser ablation, multiparametric MRI could do a better job, but if there is an equivocal lesion that was not precisely evaluated in the multiparametric MRI, either it is a post-therapy changes or there is still a residual tumor, then PSMA PET MRI could be of value. This issue is not highlighted in the literature till now. It needs more investigation, so we can try it if there is additive role of PET MRI in these patients or not.
Can I have another question? I know that Charana.
Sure, go ahead.
Okay, you know that we have like high detection rates in BRADS 4 and 5 in targeted biopsy using ultrasound MRI fusion, but we are not doing as well with BRADS 3. Detection rate is quite low, 10 to 20%, as compared to 70 to 80% in BRADS 4 and 5. Do you think that again, multiparametric MRI, when it's fused with the PET-CT, would that add value? And another thing, are you using PSMA in the PET-CT part of this combined evaluation?
Actually, the combination of PET MRI and the multiparametric MRI will increase the sensitivity for equivocal lesions, especially lesions with PIRADS 3. So if they are showing increased PSMA uptake in the PET MRI, and they are showing grade 3 by the PIRADS scoring, so we are dealing with a more suspicious lesion rather than being just an equivocal lesion by the multiparametric MRI. So I am guessing that it could be of value to upgrade these equivocal lesions of PIRADS 3 by the multiparametric MRI to identify that they could have a potential malignancy.
If I can also add, this is Yasser Abdulazim. Hi, Professor Dr. Hassan Shakir. Can you hear me?
Sure, I can.
This is a very, very interesting question by you, because in the multiparametric MRI, we are always have difficulty with these BIRAD 3 lesions, especially if they are in the central zone, which makes it rather more difficult because diffusion is not as helpful as in the peripheral zone. So I think the PET MRI with the PSMA tracer will let us pick up more actual and real cases of malignancy, particularly in the central zone, which were called as BIRAD 3 because we didn't have enough tools and enough confidence to upstage them. So I think the short answer for your question is yes, I am sure that we will have a higher confidence rate for such lesions.
Thank you very much, Dr. Yasser. Thank you very much, Dr. Rasha. That was very informative.
If I can have 2 quick comments before going to questions, I just want to emphasize things that have been said by all of us. Number 1 is we didn't want to go to this very much because it's in the more physics part, but since it was mentioned, we are going to highlight it. In PET MRI, because the MR exam itself is longer than the CT, so you have more ample time, you have more time to get PET data. You are giving as if the patient has extra PET data. This is very helpful, especially in small equivocal lesions. And as all of us showed, these small equivocal lesions, whether they are in the liver or nodal or whatever, in the PET-CT, because there was not enough time, I don't mean not enough time, the PET-CT is like this. It makes the exam rather rapid. But in MRI, due to all our sequences, we have more ample time. So we accumulate more tracer. This increases the sensitivity and further the specificity of MRI in such lesions. So this is a point we all have to keep in mind about the added benefit of MRI, of PET MRI, I mean.
Thank you, Dr. Yasser. We have some questions from Professor Dr. Muhammad Sabri. I'll start by saying the first question that he wrote. And of course, Dr. Muhammad, if you'd like to ask yourself, please go ahead. I'll start by reading out the first question. So he's asking, do you agree that the PET MRI will be more suitable than the PET CT, especially for tumors, those with low metabolic activity and with less sensitivity to PET CT, like lobular carcinoma of breast or low avid diffusion marrow infiltration? I'm sorry, I'm not a doctor, so I apologize.
You're doing good, you're doing good.
I think maybe Dr. Wafa can answer this question.
Yes, okay. I would say shortly, yes, of course. And then to add further data to this, I can say that, as I mentioned, we are tailoring the protocol of MRI. So we are actually performing a multi-parametric MR study of the breast. So this is of utmost importance for the local regional staging. And then again, there is the higher detection value of MRI as regards the osseous deposits of these low affinity lesions. So I would say yes, it would be much better to avoid exposing the patient to radiation and performing I would say, a suboptimal study when you have another study that could give you all the data needed.
Since Dr. Sabri Al-Adi is with us and I welcome him so much, I would like to emphasize the last case by Yahya, which was actually, we faced this problem with a case sent to us by Dr. Sabri Al-Adi of a breast cancer patient, and she had a dural-based pachymeningeal extraaxial lesion, and the patient was in her late 50s. So the question was, is this a meningioma or is this a pachymeningeal metastatic deposit from breast cancer? We did our high-end multi-parametric MR. We were more inclined to this being metastatic rather than aggressive meningioma. And then when we asked for the DOTA-TET study, at that time we didn't have the PET MR, we had the PET CT. And the DOTA-TET there was no uptake in the lesion. So it was going with a metastatic deposit, not a meningioma like Yahya showed. So this is a very, very important and highlighted application. I just wanted to mention.
Thank you, Dr. Yasser. Thank you for all my colleagues in Misr للأشعة for this very intelligent presentation. My first question, please, about the marrow infiltration, not about METs, because we have a lot of debates about this issue, because many of our patients receiving prostate.
So I guess the question is about role of PET MRI in marrow infiltrative diseases, right?
Yes, exactly.
Maybe Dr. Yahya Omar can highlight this.
It's the same, Dr. Muhammad, as in PET. The lesions that are low uptake in PET CT, they of course will be low uptake also in PET MRI. So that's the added value of MRI. Will over-compromise the defect of PET, and we'll see the bone marrow infiltration from the MRI aspect, not the PET aspects, as you mentioned.
May I
add something?
Okay, can I add something for Yahya?
May I add?
Yes, all of you want to add. Okay, Rasha first. Rasha talked first. Okay, go ahead.
Exactly, bone marrow is much better evaluated by the MRI rather than on CT, and also rather than the per se PET imaging. But MRI has more additive value in evaluation of treatment response depending on the novel Dixon techniques, which include in-phase, out-phase images. And also we can stratify what is so-called the fat quantification to demonstrate that the lesion is transforming to the normal fatty marrow instead of its marrow infiltration. And this is applicable on the MRI machines nowadays by these novel MRI tools to discriminate between residual viable tumor in the marrow and also the healing lesions that could be showing similar morphological appearance on the conventional MRI.
Wafa, you have something else to add?
I was just going to say that yes, it's the role of MRI through techniques the techniques we have, including the Dixon, the diffusion, the DTI, the IVIM. All of these things can be applied for better characterization of the infiltrative process.
Right. So in short, the PET in CT and MRI will be the same, but the added value of the different MR techniques, especially the high-end techniques, this is what would make the difference. So if you have such questionable cases, I would strongly recommend it to go for PET MRI to have these better qualities. Okay.
There's another question for Dr. Muhammad Sabri mentioning the Deauville criteria. And I want to mention it's the same, yes, because the PET part in the CT and the PET part of the PET MRI is the same. So we can compare the lymph nodes, the activity of the lymph nodes with the background of the liver. So it's the same, Dr. Muhammad.
Thank you, Dr. Yahya, about replying my third question. My third question, please, about lung movement.
I think Dr. Yasser will want to answer this question. Dr. Yasser, Dr. Muhammad is asking about the lung movement and the ability to detect small pulmonary nodules.
Yes, this is a very interesting topic to me. When we started the PET MRI, everybody was coming to me and saying, the lung. The pulmonary deposits will not appear in MRI as they appear very well on CT. What you are going to do about this? Are you going to do the PET MR exam and then send the patient to do CT? Fortunately enough for us, there is a novel sequence that has been tried for the last year, especially in the Western academic environments, and we have it on our machine, which is 0 TE MR acquisition. By 0 TE, you transform your MR lung image to a CT image, because you get, by 0 TE, you get rid of everything. Only the nodules are highlighted on a background of the lung. And we tried it in several cases. Last one of them was 2 days ago. I think it's the breast case that Wafa showed, and we very well depicted pulmonary Mets with very high confidence and with their uptake. 0 TE sequence can also be used in transforming MR to CT bone window. So it has also vast application in my favorite field, with the neuroradiology, in bony Mets, in fractures, etc. So we do only PET MRI, and we can detect pulmonary Mets very accurately.
Thank you, Dr. Muhammad, for your questions. It's always a pleasure having you with us. We have another question from Dr. Noor Al-Huda. Please go ahead.
Good afternoon, everybody. Thank you for this interesting presentation. I'd like to ask about the added value of PET MR in the evaluation of response regarding the radiotherapy and the residual lesions in post-operative.
I think Rasha can answer this very nicely.
From the literature, there was a very high concordance between the results of PET MRI and the histopathological specimen for suspected diseases, as I showed in my case of rectal cancer. And this also was concordant with the conventional MRI and the diffusion-weighted image at some cases for evaluation, especially the post-operative fibrosis from recurrent tumors, either for the rectum or even for the prostate in cases of biochemical recurrence. So PET MRI will be a very beneficial role in such discrimination.
Thank you, Dr. Rasha. We have a last question from Dr. Ahmed Sayed to Dr. Wafa. Please go ahead. He wrote down the question, so I can say it out. He's asking about the case that Dr. Wafa presented about the female who had cancer 5 years ago, and then the PET MRI showed that she had many mets now. I wanted to know what she did after. I mean, how's she doing now?
Well, actually, this case was about 2 days ago. So, يعني I don't really know what the meaning of the question is, but she will definitely be in need for again chemotherapy. She already took after the cancer was discovered 5 years ago. She underwent surgery. It was a partial resection of the breast. She took chemo and radiotherapy and was on hormonal therapy. I saw her PET CT that was 2 years ago, and it was completely free. The issue was that she was presented lately with bone aches and elevated tumor markers, the CA, the CEA, several tumor markers were elevated. The PET MRI was done according to a recommendation because she had an MRI study done that revealed soft tissue abdominal metastasis. So this study was done revealing a much heavier metastatic load, and it even showed that the patient had recurrence at the operative bed. So I hope I answered your question.
I have another addition to this case, because actually I was just reviewing it this morning after Dr. Wafa initially reported it. And that what she mentioned, and she actually, it was very nice to bring this slide. The patient had, on the MRI, there was reported endometrial thickening, which was so suspicious, especially in a patient with such hormonal disturbances and non-breast cancer, that she can have an endometrial cancer. However, the PET MRI was very elegant in ruling out endometrial cancer, because it did not show any uptake in the endometrium.
Any final question? Okay, in any case, the discussion, of course, doesn't stop here. So please feel free to ask any question that you have or any concern that you might have on our email. I've shared it on the chat. It's medical_info@misrradiologycenter.com. So please feel free to reach out anytime. We would love to take you on a tour for our new Cairo branch. Of course, anytime. Feel free also to reach out to schedule a tour around the center and meet our esteemed professor if you want a further discussion with them. We'll be happy to host you, of course. Thank you all for attending, and this concludes our webinar for today.
Doha, just one thing. Lots of the participants were asking about the having a recording of this session. So do you have any way? I know it was recorded, so how can they get a copy of it?
Yes, so we have it recorded and we can share it through a link. So please feel free to reach out to the medical_info email that I've shared on the chat, and I'll make sure I'll send you a copy through a link. It's very easy to be shared.
Okay, I think we should thank everybody, and we will be announcing any further such webinars. Thank you very much.
Thank you everyone for attending.